Well, that was exciting to hear all three examples. Now we'd like to open it up to you for your thoughts, your comments, and your questions. Does anybody have something to ask about for further information from any of our speakers? Yes. Mm-hmm.
Maybe I could kick off. Thanks very much. I'm Mike Rouse from Accreditation Council for Pharmacy Education. Just wanted to, certainly on the last case, commend you for the excellent results. Can you give us a little bit more indication in terms of the specific learning? I mean, a great intervention, but what was the specific learning that you did with each of your practitioners to get to that point?
So over the 8 months, is that better? So over the 8 months, we had monthly didactic lectures that really honed in on quality improvement initiatives and how to use the tools such as process mapping and fishbone diagramming to really get to the root of the problem. We also learned in great detail about the PDSA cycles. All of that was in conjunction with the IHI modules that we completed. The special thing about our program is that we learned a lot in our bi-weekly coaching sessions with our science of improvement experts.
Yes, Brenda.
And I'd just like to add to that, in terms of education, we actually used our huddle team to help educate at the bedside. So we were very fortunate where we had our other colleagues, such as our physical therapists, our pharmacists, our occupational therapists, where we could go through a quick thing about the mobility program, or we could do some education at the time in real time about maybe a different type of sedation to choose. So I really feel like everybody benefited from that.
I'm Brenda Zeeler. With regards to the last presentation, thank you very much. I would argue that your education learning outcomes was your team communication, because you had that script, you actually came together and had a plan of care. So you may have learned a lot of QI skills and other things, but that bringing the team together in a huddle, having a consistent plan of care is probably your educational outcome.
Good comment.
Great comment. Definitely agree. And I think we've really learned that even though we're a wonderful team, we practice in silos, and it was really that interdisciplinary education that everyone benefited from.
Did you have a question, Lucy? Yes, Julia.
Interested in the last example too. You had a building the team slide and all those people listed. What was your biggest challenge with that? You've done so many good things that we can all applaud, but I'm kind of interested in what was it like to get those personalities and people together, and what was the biggest challenge? Thanks.
Thank you for that question. I think the biggest challenge is igniting the passion within the interdisciplinary team. And I think that when you start at why is this beneficial to the patients, I think it's easy to bring people on board. But just another issue was just scheduling, trying to get everybody there at the same time, because we all have full-time jobs and we're trying to see our patients. So that was one of our challenges. Thank you for the question.
I would just add to that, we had a lot of great coaching about who to choose for your team, because that's so important. Maybe you would choose someone that might not be 100% on board to try to help them engage other folks. So we had a lot of great training through the Langston about how to choose our team.
Lucy wanted to make a quick comment, and then we'll get to you.
I'm on the faculty for IHI, and one of the things we have done is to change the value equation. And I wanted to comment on Mark and ask you to comment, because we don't just look at quality and outcomes in the numerator, we also include patient experience. And you mentioned you were looking at quality of life.
Right.
And I'm just interested in that thought process.
So that's one of the things that we're proposing to collect in the future that we don't have the data for right now, but recognize the importance of having that information. So towards that question of what's the biggest challenge, I think For us, the biggest challenge in terms of getting clinical partners was having people recognize that they could do something better or do it differently. And so part of that is having a broader scope of outcome measurement to be able to say, what is the quality of what you're doing, not just this one singular measure that all inpatient rehabilitation centers have to take. What can we do to be able to improve our understanding of what it is that you're doing?
Good. Yes, and then we'll go.
Thank you. This is just an observation. I really appreciate all three examples. It's interesting that there wasn't a single mention of CE in all of it. So it seems to me that going back to some earlier conversations, like really marrying, sort of busting up the whole idea and the structure of continuing education and really thinking about continuing professional development. So I just wanted to make that observation. The other is that every example, I mean, you're talking about examples that have emerged from a commitment to a learning organization format. And that's critical in all of this, just from the system perspective.
So as part of the didactic portion, we have the 64 hours that occur in Charleston, so we do provide CE for those hours, and that's true for the residents and for the mentors that come. So it's kind of an added benefit for them that they can use that information, but it is very non-traditional CE. So I'm flying back tonight because we've got one of our intensive weekends this weekend, and so what we'll do is, instead of having a lecture, we'll have a conversation about how we want to be able to treat a particular variety of patient, and then have a patient come in and then all go see them together. So, so we'll have 16 hours together this weekend to be able to do that.
And if I didn't mention that in addition to the hands-on training that we incorporated into the learning healthcare systems, we did pay for maintenance of certification as an option for people, so that collectively we paid for that and filled out the application to make it easy for people.
Great. Just a follow-up comment, if that's all right. I mean, what's interesting is that that's not what was leading this. It was really the learning, and these were added benefits. So I like that.
Yes, there was someone from the galley.
Thank you. Karen Lacey, representing the Commission on Dietetic Registration. And my question is for you, Mark. You alluded to a little bit of what my question is in your last comment. But with the 64 hours of didactic training that you have in your residency program, how did you determine what content would be included in that above and beyond their initial entry didactic components?
There are multiple answers to that question, so I'm going to ask somebody to cut me off in just a minute. So the total didactic content is 200 hours, and so it's we have spent a lot of time trying to figure out what content can be pre-recorded that they can watch on their own, what content is sufficient that we can do it in a virtual classroom where we don't have to be in the same room, and what is important enough that we have to be in the same room together to be able to accomplish that. And so we really have tried to triage down to an essential amount, what exactly do we need to do together. We have formatted that, it's a neuro rehab program, so we have one weekend on spinal cord injury, one on stroke, one on movement disorders, and one's a combination of TBI and vestibular rehab, primarily because those are the most likely patient populations that these folks are going to see, and we want to make sure we have the chance to go over those in detail and then treat those patients with them. So.
Thank you. Zori.
Zori Talib from George Washington University, but I do much of my work outside of the U.S. So I'm thinking about a network of hospitals in East Africa where we're working with their rehab departments. And over the years, we've been trying to address the issue of how do we address the education of the staff, the rehab staff, who have some come out of some education programs that, they're different than the West. So one is, how do we incentivize the leadership of these hospitals to invest in these staff and to even consider that upskilling them is of value to them? And one of the challenges that often always is brought forth is that you upskill them and then they leave. So you could bond them for some number of years, but at the end of that, will they just leave? And then we have a huge other issue that now we have to start from scratch. So one question for you is, over time, have you seen your residents leave to get leadership positions elsewhere? And it may be okay, even in East Africa, one could say, over time, that's great, we're strengthening the health system. But for the CEO of that hospital, he's sort of thinking about his 5-year budget, and he's saying, I'm just going to train them up, and they're going to leave. So just some downstream results from you. And the second question was, again, thinking about the low resource settings, the virtual classroom is very compelling. I wonder if you can speak about the effectiveness of the virtual versus the in-person, and if that model could be perhaps expanded in a low resource setting.
So for the first question, one of the things that our clinical partners have done in their contract with the therapist is to request a 2-year commitment at the end of the residency. So they're getting the 1 year that they're involved in it, 2 years after that as part of their investment. If they don't do that, the resident has to pay that back. It is true that at the end of those 2 years, people might leave. And from my standpoint, we're totally okay with that, because that takes them and puts them in a new location where they're going to be the groundwork for potential change and a culture change there. One of our very first graduate from the first cohort just left the facility where she trained, and she's taken a director of clinical education at a developing physical therapy program. And I'm great with that. I think it's a wonderful way for her to be able to spread that information. In terms of the online portion of it, there's a skill set associated with doing that effectively, and I would say in the first year we did it, we were not that skilled. One of the questions earlier was about curriculum. We had an assumption that entry-level clinicians graduated a certain level, so therefore our residency should start at that level and then progress up, and that was absolutely not true. And so what we have to do is kind of do a little bit of remediation to get back to that level and try to take them beyond. And so in organizing the online portion, I think the first year we kind of overwhelmed with content. Now what we do is, it's like, okay, you go do some content on your own, come back and lead a discussion with your peers. Bring examples of, instead of having a journal club, give us an example of an article that you found that has impacted your practice, and take a video of a patient you tried it with and come back and let us know why that's different than what you found in the literature and what you might need to adapt in a real world environment. And so it's very practically oriented as opposed to being information based.
Thank you. Any questions, thoughts? Whoops, Joel. Mm-hmm.
Just to sort of build off, Mark, your answer, and maybe even off of Darla's question too, I think, I get the sense that this isn't the first time that you've bragged about these programs, and they are very interesting, but I'm wondering, and this is maybe where I thought Darla was going on this, like, it wasn't about just awarding CE credits, it was about a change in the way that we practice. And so I wonder, what has your red team now adopted that the blue team didn't do? Who's asked you to export your model? Where have your students stood up a new pilot of this outside of the MUSC system or outside of Intermountain Health? Can you talk a little bit about, I don't know if I want to call it diffusion of innovation, but I will call it that. So maybe talk to a little bit.
So we're currently working on the sustainability of our project and expanding that past the blue team over to the red team. And we're hoping that once we get it very well established in the medicine ICU, that we could take that hospital-wide and then maybe even community-wide. So what's about the Langston Quality Scholars, we're just one dyad out of the 8 dyads. And so there were groups from labor and delivery, ambulatory care, and those projects have seen great success as well in restructuring ambulatory clinics and whatnot. So I think that sustainability is always an issue, and then the diffusion of innovation, to use your term, is something that we talk about continuously.
And I would agree with it. And I think one of the things that we're really focusing now is sustainability and education. So we're trying to take this to, Amy and I have talked to multiple different providers in our institution to try to get more folks involved, because we really are changing how we do things in the ICU, and that can be definitely challenging at times. So we're having structured educational mandatory sessions for nursing and providers in our ICU, and as Amy mentioned, we're trying to take that eventually to other ICUs.
So we've talked often about this whole idea of having a footprint inside rehab and to be able to grow from it, because absolutely one of our goals is to be able to spread this out. The analogy we like to use is that in the South, we can't, especially the coastal South, we can't plant grass seed. We have to lay sod. And so what we're trying to do is lay sod inside of rehab and then allow it to spread from there. And so the more people that are involved within a facility, we think that part of the culture change is the other folks outside of the residency program see what's happening with that group and with that selection of patients that are being treated by that group. Like, okay, we need to change what we're doing as well.
And I would say that we actually have evaluated this project as a project to create a generalized framework for accelerated dissemination and implementation. I mean, that was the purpose of the site visits that I did in the quantitative analysis. And part of what we have sort of codified in this is building the infrastructure for the learning healthcare system. And so what really emerged from this was really four key components. One key component was having a technical expert panel of clinical experts, basically, because as I've mentioned, this particular area of clinical care is a dynamic evidence base, and there are a lot of questions. And so the extent to which people were not adopting in some cases had to do with the lack of credence in the data that was available. The second piece was the sort of tool and resource portal, where people were sharing training tools, they were sharing clinical decision support tools, they actually shared smart phrases from their electronic health records so they could build in and not have to have that expense locally. There's a Vantage tool for comparative data analysis, because one of the best ways you can sort of move learning forward is to give people early and near real-time feedback, but also drive competitiveness. So you could see, like, are you doing better than Intermountain? Are you doing better than Mayo, kind of thing. And that proved to be really important. And the other one that I think emerged as something that was somewhat of a surprise was the shared learning, where somebody would come up with an example of how they were able to overcome something. There were a lot of people who complained about implementing the 3-hour bundle, and at Virginia Mason Medical Center in Seattle, they did the power hour. And so all of a sudden everybody realized, well, it actually is possible, and you could actually do it in a much shorter time period. So I think, the notion of how do we sort of fuel this learning healthcare system to accelerate the dissemination and implementation, especially through a collaborative, is important.
We'll have Bjorg first, and then I'll get you back there. Mark, did you want to say something?
I just want to say one more thing based on that question. So I'll give you a very specific example. In our first cohort, one of our facilities was in Sarasota, Florida. They were rolling out their electronic health records, and it didn't include any standardized evaluations for physical therapy. So the resident went to the IT department in that facility and said, we really need to have a menu with all of these things on there. And so they were able to modify it and then include that. 2 years later, we added a facility in York, Pennsylvania, went there to do our first site visit, and realized what they had in their electronic medical record was the menu that the resident had put in Sarasota, Florida. And so it's a really nice example of how that can flow within an organization.
Great, thank you. Bjorg. Mm-hmm.
So Bjorg Palstedt from the Training for Health Equity Network. I wanted to hear from you whether you had developed any kind of sort of feedback loops into the pre-service education, sort of learning from these great lessons. Is there lessons learned that you can sort of bring into the pre-service curriculum that you could share?
So because we're such a new program, we try to get feedback as often as possible. So we get quarterly feedback from the residents and from the mentors, and then we get an annual feedback also, and then we sit down with all the faculty that are involved in the program and decide what we're going to change for the next year. So there is a formal process within the residency. what has been perhaps even more interesting for us, for those of us that teach in a residency program and are also involved in entry-level education, it's dramatically changed how we approach our entry-level education also, and have recognized that it's really insufficient to focus so much on the didactic portion and then have the clinical portion be outside of our control, that what can we do within the walls of our classrooms on campus to be able to teach these clinical reasoning skills a little bit differently and to pose more practical patient scenarios.
I think we have time for one last question.
Do you mind if I?
No, please. It's because I just didn't see.
So to follow up with your question, the Langston Quality Scholars Program sent out surveys after every one of our didactic lectures, as well as an overall survey of the whole program. And then afterwards, they did did PDSA cycles on themselves per se, and they changed the second cohort based on the feedback of the first cohort.
Thank you. Yes, go ahead.
I just wanted to comment on Lucy's comment about the learning health system. I think that when we're talking about continuous professional development, we have to think beyond the formal kinds of education that we typically think about, and think about what happens in the learning working environment, the sort of incidental and informal learning that goes on. And I think that's an important part of continuing professional development as we go forward.
I know that there's several hands up, and we are at the appointed hour, but I can definitely tie into our activities, our next workshop concept, if that's what you're going to do, Pamela.
I just wanted to make a quick comment about the Langston Scholars at VCU. I think that's a wonderful idea. I assume that was development money, donor money, because Nancy Langston used to be the dean at School of Nursing. But anyway, I assume this was a project out of your scholar program. So that's another bigger picture I think that we're missing, that there was some development money, then they had these quality scholars, and then there were quality improvement projects, so it goes on and on. Did I capture that correctly?
Yes, ma'am. So the money came from our health system. So our health system, I believe, upfronted the money of the Langston Center, and then through the money from the Langston Center, the Langston Quality Scholars Program came from that. But yes, ma'am, it is in honor of Dr. Nancy Langston.
Great. Well, we're at that bewitching hour where it's time for a 1-hour lunch break, and we're going to meet back in this room promptly at 1:15. But so there's lots of times over lunch to keep asking our panelists questions, because I know there were several hands still up, and I apologize that we didn't have time for all. But let's give them a round of applause before we adjourn. Thank you. All right. So we'll meet back here in this room.